Okay, I'm going to start us off. Good morning, Western Canada, and good afternoon to those of you joining in the East today. I'm Harpa Eastfeld-Keeley. I'm with the National Collaborating Centre for Infectious Diseases, and I have the honor and privilege of welcoming you all to our event today, which is called Small But Mighty, Promoting Antimicrobial Stewardship Activities in Rural Locations. Our event is co-hosted by ourselves at the National Collaborating Centre for Infectious Diseases and the Association of Medical Microbiology and Infectious Disease Canada. We have guests joining us today, but I'm just going to run through a few words to open our event. First, I would like to acknowledge that the National Collaborating Centre for Infectious Diseases, or NCCID, is hosted at the University of Manitoba, which is situated on the ancestral lands of the Anishinaabe, Anishinaabe, Dakota, Dene, Nehethawak, and Aninawak nations. It is also in the heart of the Métis Nation. And at NCCID, we strive to honor the lands and their original caretakers in our work and are committed to working with our partners towards reconciliation. We would also like to acknowledge the Indigenous peoples of all the lands that we are on today. While we meet on a virtual platform, we would like to take that moment to acknowledge the importance of the land which we each call home. And we do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. So the series I've mentioned, this is the 7th in the CAN AMS series. The full name is called the Canadian Antimicrobial Stewardship Webinars. So for short, we like to call that CAN AMS. And that's a series focused on antimicrobial stewardship interventions. We have leaders each time that leaders in AMS from across Canada, and they come to share examples of what has been done to implement evidence-based antimicrobial stewardship interventions with the goal to inspire what can be done to help slow the rise and spread of AMR. So you can check for future events or our recordings of past events on the Antimicrobial Resistance AMR Aware Canada website. So that's amraware.ca. That's the home site for our collaborative that's behind that webinar series, but also behind a national campaign. So this is what that website looks like. We'd like you to get to know this and become familiar with this website. It's the host of the series, but also of the national campaign that runs every World Antimicrobial Awareness Week in November. But it's also a site that has resources, resource repository. It's curated from a lot of our partners, stories, and the webinar. So now I have a few housekeeping points to go through. Attendees, all our attendees are on mute and the chat box is disabled. And that's just to keep down any disruptions and background noises. But we ask you and invite you to enter your questions into the Q&A box. And you'll see that upvoting is active. So if you don't have a question, vote up someone else's, and that's how that works. And our presenters team is able to use the chat box to converse in the background if needed. So today's recording will be posted on the website that I just showed you, amraware.ca. It's also on NCCID's YouTube channel. That's called Center Infection, and there's a playlist there that you can view the past events. CAN AMS Antimicrobial Stewardship Webinar Playlist. If you're having any technical difficulties, please email Crystal at AMI, so Crystal with a K at ami.ca if you have any troubles today. So now we want to run a bit of a poll just to get to know who's in our room today. So Crystal will deploy the poll, and the question is, which best describes the setting where you work? Is it a remote community, rural community, urban community? You can guess who we're looking for today, but all are welcome. We're looking to see whether we have some rural community stewardship leads and advocates out there. So I'll give you a few more seconds to enter your answer, and then Crystal will post our results. Okay. So yes, we have. I'm also happy to see some from the remote communities there. Always urban communities in the mix, but rural communities with 43% of our respondents today. That's very great. So now we'll move on to one more poll question, and poll number two. And this asks for your opinion on, do you think there are opportunities to implement antimicrobial stewardship interventions in your setting? That might be a yes, maybe, no. So I'll ask Crystal to deploy the poll. You can type in your answers just over the next several seconds. We'll give you half a minute there. And I'll give you a little hint that later after the presentation, we're gonna pose this question again. So that's your cue to both pay attention and well, maybe we'll see some changes over the course of the event. So look at that. We have lots of optimists, I think. Well, I should ask Crystal to first close the poll and post the results. Okay, so look at that. Really an optimistic crowd here. 85% say yes. Look at that. I think our work is done. No, it isn't, but we'll stop the poll there. We still want to hear from our speaker to hear more about the stewardship interventions. So now I'm going to invite Jason Van Stone. Jason is a good friend of ours, part of our working group on the CAN AMS series, and I'd like Jason to take the mic, and I'll advance the slides for you, Jason. So Jason's a research scientist in stewardship and clinical appropriateness at the Regina General Hospital at the Saskatchewan Health Authority. You can say more to introduce yourself if you need to, Jason. Go ahead.
Thanks, Harpa. I think that pretty much sums me up. I've been working in the antimicrobial stewardship world for, I don't know, 9 years or so now. So this is, I guess, needless to say, near and dear to my heart. So thank you to yourself for the intro, and thanks to our host organizations for hosting this webinar series. An unbiased opinion, I think it's fantastic. So. And then I guess we're talking next for the objectives today. Yes. So Kat's going to be speaking to us. Hopefully by the end of the session, everyone here will come away with a deeper understanding of the circumstances that influence antimicrobial stewardship decisions in rural settings, ideas for potential supports, resources, and other opportunities for AMS that could be helpful in rural community settings, and have some knowledge of evidence-based approaches that can be implemented in a small community hospital setting, including auditing, antibiotic timeouts, prescriber education, and advocacy. So you will all have access to the question and answer box there, so you can throw your questions in for Kat as we go through the presentation. So it is my pleasure to introduce Catherine Neal. She is a senior pharmacist at the Lloydminster Hospital here in Lloydminster in Saskatchewan. So Kat graduated from the University of Saskatchewan in 2011, completed a hospital pharmacy residency program in Regina in 2012, and shortly after she moved to Lloydminster to work as a staff pharmacist at the hospital there. While working frontline, she enjoyed working on research projects on the side, and after completing the Society of Infectious Diseases Pharmacists course, she discovered that projects involving antimicrobial stewardship were her passion, as they are for us all. In 2023, she moved into the senior pharmacist role in Lloyd, and that allowed her to dedicate more time to stewardship efforts. When she's not at work, Kat can be found gardening and fruit picking on their acreage just outside of Lloyd. She loves to cook, canoe, and camp, and enjoys doing these things as a scouter with her kids' Beaver Scouts group. So thank you very much, Kat, for presenting to us today, and I am looking forward to everything you have to say.
Thanks, Jason. Okay, I'm going to just share my slides here. Okay, does that look the way that it should? Awesome. All right.
Yes, that's perfect.
Thank you. Okay, yeah, so as Jason said, I'm Catherine, I'm from Lloydminster, and I'm really, really happy to be here to talk about antimicrobial stewardship efforts in Lloydminster with you. So we are a border city. I don't know if you've seen Lloydminster on the map, but we're right in between Alberta and Saskatchewan. But our hospital is on the Saskatchewan side, so we are part of Saskatchewan Health Authority. Our vision is healthy people, healthy Saskatchewan, which I really think ties into antimicrobial stewardship nicely, because we can talk about the benefits to individuals as well as to the whole community. So I am happy to be part of the SHA. All right, where do you start as a rural practitioner trying to get antimicrobial stewardship going? So it might feel like some rural facilities don't have a lot of resources to get this going. And you're probably right. I don't think that my facility has a ton of resources available. But don't reinvent the wheel. There are lots and lots of resources out there that you can just steal from. I know that the stewardship program in Saskatchewan is quite strong, so I've stolen a lot of resources from them. I've kind of picked some stuff from the CDC. Public Health Ontario is really great as well. And I've also taken some tools and resources from the National Collaborating Center for Infectious Diseases. So I haven't really done a ton of creation of tools or research myself. I've just kind of been using what's available out there because there is a lot about stewardship out there already. Yeah, and don't worry, I didn't worry too much about researching the evidence base. I haven't done a lot of lit searches and lit reviews. I know that when we were talking about the objectives for today, and we were talking about what's evidence-based in rural practice, I didn't look at the evidence all that much because people have done that for me. I just kind of want to highlight the Public Health Ontario website. It's really, really great. It has a tool available that goes through the different strategies that you can employ for stewardship efforts. And it does give each of those strategies a priority level as well as a difficulty level. And then it does show the evidence that it actually backs these interventions. So the information is already out there if you're a rural practitioner and you don't have time to do the searching yourself. Also, just kind of lean into the fact that the imposter syndrome is real. For myself as a rural practitioner, and I've heard some of my other friends across the province describe this feeling as well. I kind of feel like I'm a generalist. I'm kind of a jack of all trades, master of none. There's always in the back of my mind as a rural practitioner, well, there's somebody in the city that knows how to do that better. They are a specialist. They know how to do these things. I don't know how to do these things. Just try to forget all that and just realize that to be an antimicrobial steward doesn't mean that you have to be a specialist. An infectious disease specialist to me and an antimicrobial steward are two completely different things. I know I'm an antimicrobial steward and I know I am not an infectious disease specialist, but I do know where to look and who to ask to find out if there's a piece that I need to look into a little bit more. So my other recommendation would be just to kind of lean into it and just go. As Rick Moranis said in the 1987 classic Spaceballs, what are you preparing? You're always preparing, just go. And sometimes I really, really take that strategy to heart, almost to a fault sometimes. But the nice thing about working in a small rural setting is that fixing things on the fly is so much easier. Because your teams are so small, it's really easy to use your daily huddles to check back on new processes and kind of fix things as they come up. I don't think in a small setting you have to sit and troubleshoot what all the different problems might be for an intervention before doing it. I think that you take a little bit of time to do that, but kind of just go and try it out and see what happens and then fix things as they come up. That's the way I have been living for the last couple of years, and it's going okay for me so far. And I would also recommend that you get in touch with your closest infectious disease colleagues. So here in Lloydminster, we do have a little WebEx group with the stewardship team in Regina, the Stew Crew. So we will often post questions or interesting things that we've found on there just for a little bit more support. I have also done whatever I can to hunt down our infectious disease pharmacists in person at conferences. So I am lucky enough to have been able to hunt down Melissa, who's one of our amazing pharmacists in Regina, make her play cards with me. at conferences. I've also been able to hunt down Kristen as well, who's been instrumental and just always available to give advice. In this picture here, I also wanted to highlight one of our pharmacists, Stacy. So she's a staff pharmacist here at Lloydminster, and just how important it is to have kind of like the first follower. So, I'll say, we should do this program. And Stacy has been an amazing pharmacist to say, hey, you know what? I want to do this. I want to legitimize what Kat's saying, and I'm going to get on board with enthusiasm. And she has, and it's been really, really great. So I'm so lucky to have a great team at Lloydminster and wonderful supports across the province. So get in touch with those people in your areas if you can find them. Now let's talk about some of the strategies that we have been doing in Lloydminster. So we have done some auditing. We've started timeout tools. We've been doing some education and advocacy, penicillin allergy delabeling, and indication listing. So auditing was the first step that we did. We wanted to do some small quality improvement-based audits, just so we could get a baseline, so we can see if our interventions are actually working. We also wanted to see, is there a certain area that we need to kind of target or to work on? And I had done, as a staff pharmacist, I'd done some auditing in the past, and it was more disease state specific, but it was really, really labor intensive. We were like combing through charts. I made up my own methodology. There has to be an easier way. Well, there is an easier way, and this way is accessible to everybody in Canada. So I'm not sure if this group has talked too much about the National Antimicrobial Prescribing Survey, but I'm just going to go through it a little bit because it's quite amazing. It's quite easy. So it's a national database, and it allows for benchmarking. So Canada, keep entering data. I know when I first started doing NAPS audits, NAPS is kind of what we call it here in Lloyd. There were 2 sites in Canada that had inputted data, so I actually couldn't even benchmark. And I'm happy to say that now there are 14 sites in Canada that have entered some information, but like keep entering. The more information we have, the better. I really, really like the NAPS audits because they have a well-defined methodology already. There's just kind of like a 20-page reference material that you can use to discover what kind of methodology you should be using in your hospital. It's a web-based platform, so you can use it on any device. And it's probably cleared by your privacy department already. I know it is in Saskatchewan. It can be tailored to small hospital or to large hospital, and you would just use a slightly different methodology depending on what size of hospital you have. And I really, really like it. It's so easy because data collection can be done with many members of the team. So I'm generally involved with the auditing, but we've had pharmacists kind of cycle through. So anybody who's interested can actually help take part in the audit for a day. We've had students help us out. We've had the technicians help us out. I have invited physicians and nurses to spend a day auditing with us. No one has taken us up on that so far, but maybe they will soon. And it's fairly small. An audit can be done with as few as 30 charts, which in my experience, you can generally get that in a day, just depending on the size of your hospital. And I really like the NAPS audits because they assess not only the number of antibiotics, but also the appropriateness, which I think is really important. And the NAPS methodology gives a nice little table just trying to help you fit your cases of antibiotics into whether they're appropriate or inappropriate or optimal or suboptimal. And even though, of course, there is some subjectivity involved, I have found that generally most of the cases that I come across, I can actually fit quite nicely into one of these categories. So it is quite easy to use. And then the other thing I kind of think about too is thinking about what is this actually for? So for us, we're not publishing anything. Nothing has to be super rigorous. So I always just tell the pharmacists, especially, they're kind of nervous about starting out with the audit. They're kind of afraid they're going to categorize something wrong. And this is just for quality improvement. It doesn't have to be perfect. And I think really having that mindset of just do the best that you can, it really helps to be able to include a lot more people in the auditing process and get people more invested in our antimicrobial use. So just to briefly take you through some of the information that we found in our baseline audit, we did this in September of 2024. So on day one, 50% of our patients received an antibiotic in the previous 24 hours. So we're really kind of just hoping to move that number a little bit. And what's so nice about the NAPS program as well is we inputted all of our information and then I pushed a button and it spit out all of these charts for us. So you don't have to take a lot of time with data analysis either because the NAPS program does that for you. So just briefly here, 40% at our baseline, 40% of our antibiotics were compliant with our guidelines. You can see that 17% were not compliant with guidelines. Either there was no guidelines available or a large, actually like 15% of our cases, we could not assess, like try as we might, we scoured the charts and we just could not find a reason for that antibiotic to be on board, which is interesting. When we look at appropriateness, we found that about 46% of our antimicrobial use was appropriate. So that would be if it was deemed optimal or at least adequate. You can also find information on how much you use antibiotics and what proportion of that use is appropriate. So I didn't really see any super glaring problems. Amoxiclav was maybe a little bit funny, but I think that was mostly due to some problems with the duration of amoxiclav. So based on this information, I didn't feel like we needed to target any drug specifically when we started. And you can also categorize by disease state, which is really cool. We can see that our cystitis and our surgical prophylaxis maybe wasn't the greatest at baseline. We can see how much we were documenting the indication. So only about a quarter of the time were indications actually overtly documented in our facility. And a reviewer stop date only documented 40% of the time, and 2/3 of our surgical prophylaxis exceeded 24 hours. So that was just more to give you examples of all the neat little things that you can pull off the NAPS program. It's really user-friendly and it's really cool. You can also pull your own raw data out of the NAPS program and analyze it as you see fit. So I just did that with looking at prescriber specific practices and information. So I did categorize each prescriber specifically, and I gave them all like a little code name so that I didn't like embarrass them too much in front of their colleagues. And I told them, if you want to know which code you are, you can come and find me. No one did, but maybe they will in the future. And that kind of leads us into the next portion of the presentation, which is what did we do with this information? So on the outset, we just used it to do some prescriber education. And I just took a little snapshot of the Public Health Ontario tool that I was talking about at the start of the presentation. And it just showing that prescriber education has been shown to have some positive outcomes in drug utilization, prescribing outcomes, and reduction of C. difficile. So I did present this information to our hospitalist team. They have responded quite well to previous audits. When I talked to them about this, it was a little bit harder to swallow. The room was a little bit quiet. I think that it wasn't hostile in any way, but I think that they were all surprised that our antibiotic use was so poor, that we were not optimal in most cases. So I have been able to reach the hospitalist group really well. Reaching the other physician groups has been a bit of a challenge. We don't really have like a great forum to reach those physicians. How do we've been kind of spitballing, trying to figure out how to reach all these physicians. Our chief of staff says we should get like a fancy supper going and you can present all the information. We're in the works for that. We'll see how we go. And then what I saw one of my colleagues from Estevan do, Shannon from Estevan, a pharmacist, she did a NAPS audit and she just sent a quick little email out with a little embedded 10-minute presentation just to all of her physicians and nurse colleagues. And I thought that was a really good idea. So I'm definitely going to steal that idea in the next few weeks here. All right, so we educated our prescribers, but we know from some of our previous auditing work that didn't really result in a large practice change in our hospital. So we decided to use a different strategy. We decided to go with timeout tools or TOTS. So just again, looking at that Ontario Public Health tool, scheduled antimicrobial reassessments or timeouts does have evidence to improve drug utilization outcomes and reducing antimicrobial resistant organisms. So it was apparent during our NAPS audit. So one of the questions in the NAPS audit is, has this antibiotic had a formal review in the first 3 days of therapy? And in our baseline audit, none of our antibiotics did. And the reason for that is that we don't have a formalized process in place. So we decided to try to put a formalized process in place. So we developed we didn't develop the antibiotic timeout tool. I think I got this from the CDC website, and I kind of just took it off the website, and luckily it was a Word document, so I just kind of adjusted it to our needs. And this is the tool that we use. So it lists the antibiotics. You have to determine what the indication for the antibiotic is. And then it has a list of indications that don't need antibiotic therapy. And it also helps to ask and to prompt questions like, can this antibiotic be stopped? Can the duration be limited? Can the spectrum be narrowed? Does the spectrum need to be broadened? So it kind of takes you through all the questions that you should be asking as an antimicrobial steward. So I took this paper, I adjusted it, and in the last several months, I have made some little tweaks on it here and there. So it's kind of always a moving process. And so now what we have in our pharmacy department is a list of all the antibiotics that were written 48 hours ago, prints off our printer every morning. So then the pharmacist, when they have a few extra minutes, can do an assessment and then speak with the physician or leave this note as a chart note in the chart and see what happens. So what did happen, you might ask? Well, since the start of 2025, pharmacists evaluated 111 antibiotics. 70 cases were appropriate and no recommendation was made. The other cases, we did have recommendations made, and 71 of those recommendations were accepted, 10 were not accepted, 1 was partially accepted, and 12 recommendations had an unknown result. So this is like my favorite graph to take out when I'm having little huddles with the pharmacist, because sometimes they'll come up to me and they'll say, oh, it's so frustrating because I just had Dr. X and I just made 3 recommendations and he declined every single one of them. And it's frustrating. And I say, take a look at our numbers though. For the most part, almost all of our recommendations are being accepted. And it's just like the pharmacists are making such good cases for their recommendations, and the physicians have been wonderful in accepting them. And I'm hoping that the education that we've been doing with them has sort of primed them for this. But one thing that did surprise me when I kind of broke down the data is I broke it down based on the type of intervention that was recommended. And I was surprised to see that we were equally successful in interventions which I thought would be more difficult. So just asking a physician to actually stop a medication, I thought that would be more difficult than like the low-hanging fruit of doing like an IV to PO step down or something like that. But no, it looks like actually in the cases that we've had in the last 6 months, we're just as successful no matter what the type of intervention was that was recommended. So I thought that was really nice to see. I thought that maybe we could take a look at the interventions by disease state and see, is there any kind of disease state that we are not having to make recommendations for, that like we're doing pretty good with. C. diff was the only one. We only had to make recommendations in 40% of cases. So maybe we're okay at treating C. diff. And I was thinking, I wonder if there's an antibiotic that we're especially good at using that we don't need to target anymore. Again, vancomycin, it looks like we're doing pretty good. We don't need to intervene on too many cases of vancomycin, only about 23 cases. 23% of the time. So I guess what I can learn from our information from our TOTS over the last 6 months is that we are not bad at treating C. diff with oral vancomycin. But other than that, pretty much most of our cases do require some sort of intervention. So advantages of the TOTS, they offer us an opportunity to assess our antibiotics. And I know in some hospitals, like during rounds and things like that this is already happening. It just wasn't happening in our hospital. So this is nice because each antibiotic gets a closer look now. I think that the standardized form does help, especially if you have some pharmacists that are maybe not too sure about what they should be looking at and what they should be doing. And I really like the TOTS because they're a service that you can fit really easily into like a 15 or 20-minute period if that's all you have to work with. And if you're really, really strapped, this is a service that can be dropped. If you have 50% of your pharmacists are calling in sick on one day, like you don't have to do this and the hospital will still run. But when you do have your full staff, it's a really, really nice thing to do. And I think it is making a difference. Downfalls of TOTS, of course, it just takes time. It's more documentation. The Lloydminster team has gone absolutely above and beyond with their TOTS with documentation. So they make up their TOT. I asked them to take a photocopy of it before they put it in the chart. And then they actually will keep the photocopies and follow up and see if the intervention has been accepted or rejected. And then I kind of just receive a stack of TOTs on my desk every couple of weeks that they've been documenting for me. So they have done an amazing job of helping out with that. And sometimes I do wonder in my heart of hearts when I'm entering an antibiotic, do I scrutinize it a little bit less because I know it's going to get an assessment in 48 hours? I don't know if I'm doing that, but it's just, a possible downfall, just something to be mindful of when we're doing our TOTS. And again, I would just like to underscore, you do not have to be a specialist to do timeout tools. I would say 90% of the cases are not complex cases. They just need a little bit more care and attention. You just have to look at your local guidelines and see, is it matching up with the empiric therapy? Is it matching up with the duration? Is it time to do an IV to PO step down? We don't have an automatic IV to PO step down policy in our hospital, so it does need a little bit more care and attention from us. And we use our local guidelines. I think a lot of other jurisdictions in Canada have the First Line app. It's amazing because our local Saskatchewan team kind of curates it and makes sure that it's appropriate for our resistance patterns. So we use First Line all the time. If we can't find what we're looking for in First Line, we do use Bugs and Drugs because we are very close to Alberta where Bugs and Drugs is published. But yeah, you don't have to be a specialist to do this. All right, so education and advocacy is something that we've also been doing in Lloydminster Hospital. So we participated in our first World Antimicrobial Resistance Awareness Week in November last year. So in Lloydminster and Meadow Lake, which is a smaller hospital about 2 hours away, we set up little booths. We gave out blue candy. We spent the day talking to staff members and members of the public about antimicrobial stewardship and antimicrobial resistance. And we served blue food at the cafeteria for the patient meal. And my manager, Marilyn, she's like a cricket master, and she made us all these fancy blue World AMR Week shirts to wear. So it was really, really awesome. And I did visit all the daily huddles of our departments in the hospital and asked them to wear blue on the day that we were doing these activities, and just kind of explain to them what antimicrobial resistance was. During the rest of the year, we visit high schools. I'm proud to say that so far only one student has fallen asleep during my presentations. So I talked to them about stewardship and about resistance. And our nurses do have to go to a yearly all-day education session, and they've been kind enough to give me half an hour to present to the nurses about this type of thing. And I just kind of present a presentation that's fairly similar to what I'm giving you right now. And then the pharmacy staff, we are always taking in the CAN AMS sessions whenever we can, or if there's anything coming down from provincial for AMS, we are happy to engage in that education. So I just included some pictures. So on the left there, that's Erin. She's the infection control nurse in Meadow Lake. So we set up our little booth together and accosted many members of the public on their way into the hospital. And on the right, that's just a picture of the food trays that we sent out. So in Lloydminster Hospital, we sent out a little piece of information that, again, we stole from the CAN AMS website, and we served it with a blueberry crumble that day. And on the left of this slide here, there's just Marilyn and Jackie, two of our pharmacists, talking to some staff members about AMR. And I just had to include a picture in the top right of the physio department because on every single one of them wore blue on our little AMR day. So I thought that was really neat. And just on the bottom there, that's the kitchen staff. So they all wore blue and they all were very, very happy to help support us with the food portion of our activities. All right, so let's talk about penicillin allergy delabeling. So pen allergy delabeling was something that we were kind of informally doing in the hospital. We had heard presentations from provincial before and we'd get excited about it and then we'd it would kind of fall off a little bit. Lots of times we had patients come in who kind of accidentally got a penicillin when they weren't supposed to, but everything was fine. So then we just kind of documented that in our pharmacy order entry system. But we have had renewed vigor since the last CAN AMS presentation. So thank you, Tiffany, Chelsea, and Haneen. The presentation was awesome. We all kind of walked out after watching it, like very excited to do some more penicillin allergy delabeling. And again, the thing I love about pen allergy delabeling is that it's something that you can do in just a small amount of time. And if you have to drop that service because you're short, that's okay. So again, we do have a little report that prints off every morning of all the patients with a penicillin allergy. And if we have time to look at them, we do. And if we don't, well, that's okay too. So the provincial team has really set us up nicely to do these pen allergy delabeling. So on our First Line app, they have a really, really nice framework we can use to do the assessments and to do the amoxicillin challenge if we need to. And they have really, really great papers. If you can just see the image there is the information that we give to the patients and to the outpatient providers so that everybody knows that this patient has been delabeled. So they're really, really beautiful forms. And since April, I am proud to say that we have delabeled 5 patients, which again, doesn't seem like a lot, but it's more than 0. So that's something to celebrate, I think. All right, so we have also been working on increasing our documentation of antibiotic indications. So as a reminder, at baseline, we were not doing very well with this at all. So only about a quarter of our antibiotics had an indication overtly stated. And again, we could, like with digging into the chart, we could generally find out what the indication was for, but I think it would have been a lot easier to do the audits and it's a lot easier to do your timeout tools if you know exactly right away what that medication is being used for. And I know that at one of our previous meetings, Jason was actually mentioning that there is evidence to show that requiring an indication on an order can actually reduce inappropriate prescribing. So I thought that was really neat. So what are we doing to help with this? So again, we've just been doing some prescriber education, hasn't really resulted in much. On July 1st, we are going to be switching out our physician order sheets that we use in the hospital. So we still are a paper-based charting facility and will be for many years probably. So we used to have a physician order set that just had a place for the date and the orders. And so now we have switched it out with an order sheet that has a place for indication. Now, are physicians always filling this out? No, they're not. But at least there's that little trigger there to hopefully get them to be writing that indication a little bit more. We are also really trying to have our physicians use the predefined order sets that we have available with some limited uptake, but again, just something to work on. And in the future, maybe one day in Lloydminster Hospital, we will demand that an indication is written for an antibiotic before that antibiotic is placed on the MAR. Not somewhere I'd like to go yet. And I know that the provincial group is laying groundwork with at least having a policy saying that it should be done. Maybe one day we'll be brave and we will demand that it be done, but we'll give some fair warning first. So has any of this made a difference? So I was able to do a 6-month audit, so around March, April of this year, where we could compare and then actually NAPS has again, you can push a button to compare 2 different audits over time, which is super cool. So our documentation of indication did increase from 26 to 38%. And our surgical prophylaxis being given for greater than 24 hours did reduce from 67 to 50%. Now, I did that audit, and I do know that this probably happened by chance just because we happen to have far less C-sections happen during our second audit, which we generally, unfortunately, give antibiotics for a little bit longer for. Our compliance with guidelines went down, but that's because our use of directed culture-based therapy went up. And our appropriateness of our antimicrobial use went from 46% to 55% being considered appropriate. And again, this is all quality improvement. So is it perfect? I don't know. I was the one doing the audits. Of course, I tried to be objective, but in the back of my mind, I look at this information and I think, oh, like, did I want it to be better on the follow-up audit at the 6-month audit? I don't know. I did the best that I could, and I do think that we have gotten a little bit better. And how are we doing compared to other hospitals? So yes, NAPS allows you to benchmark. So we can see my data on the left. We can see all the other 14 hospitals in Canada on the right. And this is really, really valuable information for me to have because I can look at this and I can say, okay, well, about 35% of the time, the numbers are, I combined the two audits together, our baseline and our 6-month audit to use it to make this information. So that's why it doesn't match the other slides. About 35% of the time we were compliant with guidelines, but we can look at this information and we can say to our teams, hey, across Canada, 40% of our colleagues are actually using their guidelines. So maybe it's something we can strive for. Same with appropriateness. We're deemed our antibiotic use to be appropriate about 50% of the time. That's pretty different from the 65% across Canada. So let's aim to get there. Documentation of indication. This is a huge glaring difference. We're about 30% overall, whereas the rest of Canada is doing this about 75% of the time. So it is possible. Let's get there. Review or stop date documented. We're looking pretty similar to the rest of Canada, maybe a little bit less. And surgical prophylaxis given for greater than 24 hours. Apparently, we are actually doing better than the rest of the country with this. But like I said, I think this is a little bit skewed based on just the low number of cases that we've had. Another really interesting piece of information that when this popped out of NAPS, I looked at it and I was like, how am I going to use this information? But it's been really neat. So we can look at the top most commonly prescribed antimicrobials in my facility on the left versus in Canada on the right. And so this actually kind of helps to answer a question for me that I've had over the last few years, because I know that when I look at community-acquired pneumonia, should we treat atypicals or should we not treat atypicals? We generally go with the treat the atypicals strategy here in Lloydminster, but I know that that's kind of up in the air and maybe isn't what we need to be doing. When I look at the numbers for azithromycin, that's our second most commonly used antibiotic, and I can tell you right now it's because of our caps. When I look nationally, only 5% of antibiotic use is from azithromycin. So, I mean, I'm just guessing, I'm just inferring, but considering cap is probably pretty prevalent all the way across Canada, I'm wondering if maybe other facilities are not treating atypicals. So that's some interesting information that I actually have to talk to our provincial program about, because I don't really know what to do with that information, but it's certainly nice to have it. All right, so what have I learned through this work? Maybe more preparation for physicians would have been good, may have reduced some pushback. It might have done nothing at all. I don't know, but it would have been maybe better to prepare them a little bit more. One thing I didn't anticipate at the start of this work was realizing that there's kind of like a pecking order that I didn't really understand before. So like when talking to the hospitalists who are easily accessible and we're talking to them about antibiotics and they say, well, that's all well and good, but if the internist comes in and writes an antibiotic, I'm not going to stop it. So, oh, geez, I should have maybe targeted the internists a little bit more. A more formalized committee is probably needed in Lloydminster. We're kind of just doing, I wouldn't call what we're doing a program. I would call it just like activities. But we probably need to get a program in place, a committee in place to provide some accountability, to provide some support, to maybe get a little bit more interprofessional involvement. I know you've noticed that most of our interventions are pharmacist driven. It would be nice to include some other disciplines as well. And I know that our provincial group does have the groundwork laid to help each facility make its own antimicrobial stewardship committee, which I'm just kind of starting working on right now. Another thing I've learned is that it really is hard to do off the side of your desk. We did a few activities when I was a staff pharmacist. It was only when I became a senior pharmacist and got a little bit more office time that I was able to really kind of spearhead this work. But even so, it's not the only thing I do. That's not the only part of my job. So it is hard to kind of carve out time to do it. And it does take a lot of energy to keep it going. Dealing with opposition is hard. Dealing with apathy is almost worse. So it just, you have to really be passionate, and you have to just kind of try to keep that excitement going, because not everybody is as excited about antimicrobial stewardship as I am. But keep on going, I guess. So in summary, yeah, we've been working on auditing, timeout tools, education and advocacy, pen allergy delabeling, and indication listing in Lloydminster Hospital. Thank you so much, and I'll maybe pass it over to Jason for some questions.
That was wonderful. Thank you, Kat, very much for that entire presentation. Very inspiring, I think, to see, some of the work that you guys have been able to do. And so we've got some questions already in the chat. So we'll start answering some of those, and people, please feel free to keep throwing questions in there. So let's start, I'm just going to start at the top here and kind of go through. So I think Kathy was asking this when you were speaking to the NAPS program, the National Antimicrobial Prescribing Survey, and she was just wondering if there is a program for community clinics to assess the same concerns.
Not that I'm aware of. Honestly, because I'm a hospital pharmacist, I haven't really looked into it. So I apologize. I can't answer that question.
I don't think there is either. I was scratching my head, and I'm like, I think, because I don't think you could adapt NAPS to a community program because it's a different baseline or denominator that you're using there. I might put in a quick plug for CPSIN. So if people have not heard of CPSIN, the Canadian Primary Care Sentinel Surveillance Network, CPCSSN. Actually, I can put that in the thing. And I think their website is just cpsin.ca, CPCSSN. That is, it's not in the same vein as NAPS, but what it does is your primary care clinic or community clinic would provide your data to this network. They have built-in dashboard, reports that you can get back, one of which is around antimicrobial use. So it doesn't necessarily give you your appropriateness per se, but you can use that data to dig in deeper. So I'll put a plug for that one in there. Here is from Alana. Flagyl and Ancef are often used prophylactically in an OR, in her experience. Are they counted as incorrectly prescribed because they don't meet the case definition for infection?
So there was in the NAPS program, they do allow for appropriate use of prescribing surgical prophylaxis. So anything that would be given pre-op that is appropriate for that operation would be considered appropriate. It's just if it extends a little bit longer, that's when it starts to become inappropriate.
All right. Deanna's giving, she loves your enthusiasm and energy. So I would second that. And she also put in a plug too, if everyone has access to the Q&A there, a plug for the antimicrobial stewardship rounds that they host out of Alberta. Last one today. But you can email Deanna to get connected to that if you'd like. Cool. Great presentation. Curious about staffing for your program. Do you have a designated time or FTE to support stewardship? And if so, how did you make the case for it?
No, we don't, actually. So what kind of happened at our facility is I just kind of fell into this at a really good time, because when I came into the senior role, and I'm very excited about antimicrobial stewardship. So that's kind of where, if there was anything extra that we wanted to do, that's kind of where I directed us to go. Our technicians in our hospital just started checking our chemotherapy, which used to be a pharmacist's function. So it's just kind of lucky that we sort of fell into a time when we actually had a little bit more time liberated for the pharmacists. But no, we don't have any additional staffing. We just kind of fit it in as it comes. And I got to tell you, for timeout tools is the biggest thing that our staff pharmacists do. And some, like in the month of March, for example, we were short that entire month because of a big holiday, and we hardly did any. And then the next month we did quite a few more. It just kind of depended on staffing. But for the audits, yeah, it actually, like the auditing, we don't have an additional FTE for, just because we do it like every 6 months. You can do it every year. And it takes like 3 people 1 day to do it. So it's just kind of easy to workload for that, but no, nothing specific.
I think building off that one too, Aaron is asking, how big is your hospital in Lloyd?
Oh, that would have been really good information to include in the presentation. Yeah, so we have 60 beds, 40 of them are medical beds.
Yeah, I think the wonderful thing too that I picked from your presentation, or pull from your presentation, is the amount of data that you guys are capturing with this. That can go a long way to making that case for, you know what, we need some dedicated FTEs to help drive this work and build on the work that you guys are doing, so that you can have dedicated antimicrobial stewardship pharmacy support, that kind of thing, or for building that committee or a more formalized program. So that's a great piece too, is once you start doing things, make sure you're capturing that data about the interventions that you've done, and so you can compare your data over time, as Kat's been able to show.
Yeah. Well, another thing, Jason, with that too, is just collecting the data is one thing. But like, for example, like when I said I'm not an expert in infectious disease, I'm also not an expert in like business cases and that kind of thing. So even if you just have the information available, there's often a colleague somewhere around that you can find to help you out with that.
Absolutely.
So don't worry if you don't know how to do it.
Yep. We have from both Caitlin and an anonymous attendee, so we'll do 2 birds here. Where can I find the form for penicillin allergy delabeling? And Caitlin's question is, what is penicillin allergy delabeling? She's just not familiar with that.
Oh, okay. So penicillin allergy delabeling is just taking a patient. So so 10% of patients describe a penicillin allergy, less than 1% are actually allergic. So this is kind of the spiel that I give patients when I talk to them. So patients who have a penicillin allergy on their profile are at a higher risk of developing C. diff, of being having resistant organisms colonized in their body, MRSA, VRE. They're at a higher risk of treatment failure and of having broader spectrum antibiotics. So it's in our best interest to take a patient who has a penicillin allergy and actually confirm whether or not that allergy is true. And so we actually have a form. It's on our First Line app, but I do know that RX Files also has some excellent delabeling information if you don't have Saskatchewan resources available. RX Files does have some nice stuff there as well. And we just kind of go through, and it prompts us to ask all the questions of trying to determine if this allergy is a real allergy or maybe an intolerance. And then once we determine if the patient is probably low risk or probably doesn't have an allergy, we can outright just say, no, you don't have an allergy. Or we can offer to give them a 500 milligram amoxicillin test dose. And if that goes well, then we get all the documentation ready and we make sure that everybody in their circle of care knows that they're not allergic to penicillin anymore. Unfortunately, those forms, and Jason, maybe you can speak to this, I just got them off the Saskatchewan Health Authority website because they're made by our stewardship team. Do you know if those are available outside of SHA, Jason?
It would depend on your organization and whether they've got similar forms already, or where you'd be able to adapt things from something that already exists, I think. So as far as the tool itself, yes, it's available through First Line, or like you said, there would be other things through RX Files and things like that. But the forms for then kind of all of the relevant information that goes along with the patient, I think, yeah, you just have to see if it's available in your organization or adapt from elsewhere. Yeah. A couple questions related to long-term care. So Kirsten and Deirdre asking, would this be, do you think this is a program that can easily be implemented in long-term care homes? And Deirdre asking specifically about a small long-term care home. They only have like 2 to 3 in-house prescribers.
Mm-hmm. I mean, the smaller it is, the easier for sure. I guess it kind of depends on your, yes. In summary, yes, I think it can be adapted to those locations. Who's going to do it is the question. Now, as I go through and think about it, the NAPS auditing, I know I've asked nurses and they haven't really felt comfortable doing the assessments. But it is possible to at least assess some of them as long as you have really strong local guidelines in place and available. When we're talking about the 48-hour or 72-hour assessment, like the timeout tools, I was thinking about this at home today, and I was thinking it's great to do by pharmacists, but I also think maybe like a nurse could also do it. Again, all you have to do is lean on those guidelines that we have, and the principles are not complex. It just takes care and attention. So yes, I think you could do it in long-term care, and maybe even like as a nursing-driven program.
Yeah, absolutely. I think there's a couple long-term care facilities in Saskatchewan that have started up antimicrobial stewardship committees, and it is nursing, pharmacist driven, depending on their ability. So yeah. Ellie or Eli has a comment, more of a comment than a question. I'll just read it out here. Sounds like you have a great team at Lloydminster, and I think it's great how you've highlighted that you don't need to be an expert to start practicing stewardship. I definitely agree with that. Another thing for rural hospitals that they struggle with, perhaps that are smaller or perhaps more remote, is not having sufficient staff to work on stewardship endeavors or even starting them, which I think is something you've touched on here. So a couple of us in the audience are part of Northwest Telepharmacy's antimicrobial stewardship program, and just wanted to share that with telestewardship, these staffing struggles don't have to be a barrier. I know that was something that someone had sent in as well. So I don't know if you want to touch on, Kat, any kind of technologies for remote prospective audit and feedback, other sort of stewardship activities?
Like someone's got to be there to look at the chart to do it. So it is tough. I mean, could it be done over the phone, like by a pharmacist talking to a nurse? Yes, it could be done. Maybe you could eliminate that middleman and have a nurse doing that right on site. I don't know any technologies that could help with that.
Yeah, I'm not, other than the usual telehealth and those types of things. But yeah, I think that's where it comes down to people just, being creative, finding ways to make connections and get information to the people that need it. So
yeah, for sure. Well, and even like with the NAPS audit, like the auditing part anyway, it doesn't have to be done often. So I know I do go to Meadow Lake, which is 2 hours away, and I have done some auditing there just when I'm there. So it just might be more intermittent, but it is possible to get some of the conversation started.
for sure. I got my warning, my 2-minute warning from Harpa, so we're going to have to stop there, unfortunately. There are more questions. I think we'll be able to share those with Kat so she can possibly respond by email or things afterwards. I recognize at least some of the names that are there. As well, I think Kat provided her email at the beginning of the slide there, so you can always reach out to her directly. So thanks very much, Kat, for this, and I will pass it back to you, Harpa.
Thank you, Kat. Thank you, Jason. That was just fabulous. And we're seeing all those great comments in the chat, and people are sharing information too, it is wonderful. I'm just gonna, whoops, I'm on my wrong slide here, but I'm gonna go to poll number 3. Here it is. So now we're going back to our poll to check in with you. Do you think there are opportunities to implement stewardship in your setting? Has this changed any? Maybe we'll see. You were already so optimistic, so I don't know. It's going to be hard to move this needle. So we'll just give you a few more seconds to respond. And now we'll close the poll. Look at that. Well, I don't know. It's we're all still thinking and taking in this great information, but I think it is really positive to see this this kind of result among. I think we're acknowledging the lack of resources, and yes. So we'll go on from here. So we'll just take down the poll, and. I just want to let you all know that we're taking a little bit of a break for the summer. Do go back to past CanAMS webinars. There's one on penicillin allergy delabeling, and I know many have been sharing other direct resources like Drop the Label website, but go back to our past webinars. We have another one coming in October. That one's going to be called Turning the Tide on Resistance, Local Leaders, National Goals. So we're getting a wonderful panel together of some of the provincial leads working to implement antimicrobial stewardship actions in their region and really called to the challenge of meeting the goals set out in the Pan-Canadian Action Plan for AMR resistance. So we're going to hear from that panel about some of the realities in the regions for implementing stewardship, how that differs in the regions, some of their different starting points and approaches. So do tune in. We'll announce the date, the October date, on the amraware.ca website late this summer. So here are some of our amazing panelists that are joining us. Thank you for attending today. Thank you for presenting and participating so actively, enthusiastically on AMS today. Today's recording, again, it's on the website, on YouTube, but please take our survey and take a few moments there. You can use the QR code. Crystal, if you can share the link to the questionnaire in our Q&A area. So yes, use the QR code and please complete the survey. We'd love to be able to continue sharing more of these events with you. And with that, I'm going to close the event today with a great big thank you to Catherine for sharing so openly the amazing work that they're championing in Lloydminster, and to Jason for so deftly supporting our conversations today. Thank you all.